introduce Audrey Lowe and Nancy Littke to speak to us about the Reflective Practice Review Program. Nancy Littke is the Competence Committee Chair and Physical Therapy Clinical Educator of the Interprofessional Student Service at the Glen Rose Rehabilitation Hospital. She's been a Competence Committee member since 2014 and a two-time auditor of the Reflective Practice Review Program. She conducted the pilot test of the Patient Care Reflection Tool for her Master of Rehabilitation Science project. And Audrey Lowe is the manager of the Continuing Competence Program. She administers the Continuing Competence Program and is the staff support to the Competence Committee. And so with no further ado, it's my pleasure to introduce Audrey and Nancy, and I'll hand it over to you, Audrey.
Well, thank you, everyone, for attending. I'm going to start off, and Nancy will come in midway. On the right-hand side with the green box are the objectives of this presentation, and they are here to help you be successful in completing your reflective practice review materials and participating in the audit of your reflective practice review documents. By the end of the audit, I want you to know where to find the materials for the reflective practice review on our website. Come away with a better understanding of the audit process and criteria. See examples of satisfactory and unsatisfactory reflective practice review documents. We'll go over some of the audit results and also have a greater appreciation of programming assumptions and where we are with evolving the continuing competence program. The end result is I hope you will have increased confidence about finding information about the program and also meeting the program requirements and interpreting, if you are audited, when you receive your feedback letter, interpreting the results. And again, we're using the survey not only to get your opinions on the webinar, but also to improve the program. So please take the time to complete it at the end of the presentation. So the first thing is participation in the Continuing Competence Program is required for ongoing registration with Physiotherapy Alberta. So it's a registration requirement. So if you are going onto the website, you go to the Physiotherapist tab and how to maintain your registration. And from there, what pops up is the program. And the two components are the reflective practice review and jurisprudence. So on the right-hand side, on the bottom, is what pops up when you click on reflective practice review. Our main form of communication about the program is through the website. We try to keep it as up-to-date as possible, and also through newsletter articles. And I write monthly newsletter articles to help improve understanding about the program, but also continuing competence issues. We have links on our website to those articles, and one of the handouts has links to the articles and different topics. So in terms of continuing competence programming, the government prescribes through laws what regulatory organizations are to do, and regulations basically are the systems and mechanisms that regulators implement to evaluate and promote the attributes required for safe and effective physiotherapist practice. And with the introduction of the Health Professions Act in 2000, we were told that we have to offer a continuing competence program. And this really has represented considerable changes in regulators' approach to looking at members' competence. And the reason is, prior to introducing continuing competence program requirements, monitoring of members' behaviors after initial entry to the profession was through a complaints-driven model. So now, under the Health Professions Act, Physiotherapy Alberta has two mechanisms to monitor members' practice behaviors. One is through the complaints process, and the other is through the continuing competence program. So continuing competency programs as a concept and implemented in the regulatory context is the concept's about 25 years old, and programs have been in place for about 15, and it's really only now that the various program strategies are being being known. And Physiotherapy Alberta has only implemented their continuing competence program in 2012. So we're still in the early stages of program implementation. Our program, the Health Professions Act, says the program must allow for members to maintain competence, enhance the provision of professional services, and provide for practice visits. And we do have the authority to conduct practice visits. Implementing continuing competence programming is challenging because you're trying to create a program for physiotherapists, and 99% of them are doing a great job. We have to develop a program for 2,500 physiotherapists working in 29 different practice areas and 13 different practice environments. And competence is multifaceted and multidimensional, and there are at least 7 approaches to competence programming that you can use as the guiding philosophy for your strategy, and each comes with its own limitations and strengths. What we have learned is no one all-encompassing method is available that will promote and assess the multidimensional layers of physiotherapist competence. We need multiple strategies. And even with the best program, people can successfully complete a programming strategy, and it may or may not contribute to their personal competence. It depends on the person's context and how they engage in the program. So when we think about competence, it's a term that is laden with a lot of meaning. Competence is considered the composite knowledge, skills, and judgments to perform one's job. It's a term that's used to describe an individual and their ability to fulfill a professional role, but it also can be considered a state of readiness to fulfill one's future job role. We know that competence is domain-specific and context-specific, so you can be stronger in one area of practice than another. So, for example, someone can have extremely good technical skills, but their communication skills may not be so great. In terms of context, you may have the skills to function in one work situation, but that same skill set may not transfer well to another environment, or if another situation requires a slightly different problem-solving skill set, using an old approach to solve a new problem doesn't work. So when we use the term competence, we use it as an adjective. He is competent, she is not competent. We tend to have an emotional response because the opposite of competence is incompetent, and no professional wants to be labeled incompetent. So I really think, after working in this area for a long time, the language of continuing competence given to us by the Health Professions Act may be problematic because right at the get-go, it's threatening to a professional self-identity. So even if the college introduces program strategies considered to be the most flexible and least rigorous, there are some aspects of language that we use that will be threatening. They're given to us by the legislation, and we're stuck with them. So competence, continuing competence, satisfactorily meeting requirements, these are terms given to us by the Health Professions Act. This is the best conceptual definition of competence that I have found because it embodies all the different domains: knowledge, technical skills, reasoning, emotional intelligence, but it also names the population, the individual that's being served, your patients, and the community. And we also like to think Physiotherapy Alberta and our broader profession, people outside of your work environment are part of the community that you are striving to interact with. If you're looking for descriptions of competence or competencies, you're going to find them in our practice standards, the essential competency profile for physiotherapists in Canada, and your employer may have a job skill set. So again, just to stress, continuing competence programming is different than the whole idea of individual competence. They're related. Participating in a program may not lead to competence improvement. We'd like to think it does, but it may not. So here are the different approaches to competence that each comes with its strengths and limitations. I'll briefly go over a few of them, not all of them, but the knowledge construct is symbolized by what you know, and it's usually measured through written examinations. The limitations with the knowledge construct is it doesn't predict how you're going to perform. So we have everyone who's passed the jurisprudence test, but we still have people who don't remember the standards, haven't applied them to their practice consistently. In the green section is the performance aspect, our performance way of looking at competence, and it's usually a behavioral approach in which you would assess, you would observe and use a checklist to look at someone's performance. But the limitation is it doesn't really assess your thinking about what you're doing and why you're doing. Reflection is in the blue, and it's considered your ability to sit back and self-assess and reflect on what you've done, think about how you might improve, and take action to improve. It's a process that's thought to link knowledge into, you're linking knowledge or theory into practice, taking into consideration your environment and the situation in front of you. It also assumes that someone's motivated, willing, and able to self-assess, identify your own needs and areas of improvement, and act to learn and enhance practice. So it's limited because, again, it may show how a person constructs knowledge about their practice out of real-life situations, but it doesn't really show us what you actually are doing. The psychometric approach is measuring an individual's performance against a set of norms that have been established for your peer group, using measures that have been statistically proven to be valid and reliable and therefore legally defensible. So again, our national physiotherapy exam or high-stakes exams use a psychometric approach. Again, the limitation is it's getting people to move to normative kind of behaviors, but may stifle innovative kind of thinking. Production is usually an approach that focuses on meeting production standards and quality care standards. So often in healthcare we focus on efficiency, but again, a focus on efficiency may compete with other important factors for patient care, such as empathy. The other limitation, again, with production is sometimes when you focus on efficiency, you're so busy getting things done, it trumps your ability to spend time trying to think outside of the box. And finally, engagement, which is new, but the idea of competent professionals are how well you engage with the knowledge that underpins your area of practice, with your peers, with your work environment, and your broader profession. But there's been no operational definition, but we know that there is some risk factors for disengagement. And when you are disengaged, that may lead to problems with competence. So all of these concepts are behind different programming strategies that are out there. and they can be used in isolation or combination for continuing competence programming. I do want to point out that CPD accreditation, which is a common continuing competence program strategy, as a standalone strategy has been evaluated, and the consensus is it doesn't work to ensure competence. Just awarding points for time spent participating in education sessions doesn't measure whether knowledge has been remembered and, more importantly, has been applied. So there's no question that you need to keep gathering knowledge to keep current in practice, but CPD, as it's traditionally been implemented as an assessment strategy, has been found to be limited. Now, people who offer a CPD program are now starting to require additional activities from their members to demonstrate that learning has been applied, and usually that's some kind of reflection note. And they have started talking about competency-based education programs, which means you're participating in competency-based or continuing professional development, but there's an additional activity tagged onto that to ensure learning has been applied to practice. So here's our program that's defined in legislation. We have 3 boxes: competence development, competence assessment, and practice visit. And under competence development is the reflective practice review, which will be the remainder of this presentation. But I did want to say with the middle box, jurisprudence, everyone participated in the jurisprudence module in 2012, or the bulk of physiotherapists. And so the rules are you're supposed to participate every 5 years. Next year, that module, we're waiting for new practice standards to be developed for the profession. And once those standards are adopted by the college, then we will write the examination questions. So the exam will be delayed. It likely will not be offered in 2017, probably soon after in the 2018 or 19 period. And with that, the reflective practice review, again, we've talked about reflection as a strategy. So our reflective practice review, it's a cognitive educational strategy. It's intended to result in changes in one or more of the following: knowledge, attitudes, skills, behaviors, practices, or processes. It's encouraging reflective judgment and critical thinking about professional competencies and practices. The principles are that physiotherapists are self-directed and will use the outcomes of reflection and systematic learning planning to improve competence. The essential competencies for physiotherapists in Canada provides the foundation for ongoing competence assessment. Clinical reflection includes examining patient care practices and related evidence for practice decisions. Physiotherapists will use evidence to support practice decisions. Other methods of reflection are acceptable to inform self-assessment and learning. So these principles are on our website. And again, the reflective practice review is simply a framework to encourage your self-assessment and reflection and learning. We have program rules. These are the equivalent of program policies, and again, posted on the website. But the rules say that general registered members are required to complete a reflective practice review each registration year, which includes but not limited to self-assessment, a patient care reflection, learning plan development, implementation, and reporting. Your learning must be structured to achieve meaningful outcomes in the following areas: individual competence, patient care, and/or physiotherapy health services. And the audit criteria, the rules say the audit criteria for the reflective practice reviews involves establishing whether the records are complete, understandable, and provide evidence of critical thinking on the subjects addressed in each record. The records must demonstrate efforts to use current external resources to inform reflection and learning. Records must demonstrate your efforts to achieve meaningful changes in the two of the following. Again, individual competence, patient care, or physiotherapy health services. So that's what our rules state, and that's what our program, the principles of our program. So again, when we're using a reflective practice approach, we're trying to get at higher orders of thinking, where you are constructing knowledge, constructing new knowledge from what you know, how the patient is presented to you, and also your experiences. This is a different approach, a constructivist approach to education and reflection is much different than perhaps a behaviorist approach where your performance is measured against standard statements that might be used in the complaints process. And it, for the reflective practice review is different than the jurisprudence module. The jurisprudence module also uses this taxonomy of cognitive learning called Bloom's taxonomy. And it maps all the questions at these lower levels of this taxonomy. The questions are mapped as it's something that stimulates recall, understanding, or application. So we have these different processes in the college that have different educational strategies, behaviorism versus constructivism, and work at a different level of this model of cognitive cognition or cognitive learning and assessment. So I'm going to hand this over to Nancy, who will be going over the program and some of the examples.
Hi, everybody. Thanks, Audrey, for leading us into this and giving us some of the background information. I think I just want to reinforce a couple of the things that Audrey brought up that makes the reflective practice review, changes it from being just something you have to fill in to get your license and hopefully you don't get audited, to something that actually can be of value to you as a clinician, to your patients, and to maintaining our ability to be self-regulated, evidence-based current practitioners, which I think all of us want to be, and sometimes we just need a little assistance in moving along that plane. The word at the beginning of the description is reflective, and reflection is what makes us better in everything that we do. The other thing that Audrey talked about was engagement. This program, if you truly engage in looking at what your practice is, what your knowledge is, where you might be weak, if you actually engage in that process, in this process, in a thoughtful, mindful manner, it becomes a very valuable tool and not just something you have to complete at 11 o'clock the night before you have to register. There's 3 steps in the practice review. One is the essential competence assessment, and that's based on looking at the competencies that have been developed for the Pan-Canadian competency profile, and looking at how you feel you are, how competent you are, how knowledgeable you are with regards to those competencies. Those are the competencies that we are required to uphold and maintain throughout our practice. There's also a patient care reflection tool for those who are working in clinical practice where you're actually working with patients. It's a way to take a patient's journey and have a look at how you participated in that journey and guided that journey and determine, are you doing things that are still current evidence-based, or are you sort of stuck in doing things that you've always done but don't really know exactly why or if they're still current? And this is an opportunity for you to look at what you've done in a clinical way or in a reflective way and see where you could do better, how you could have improved things, what you might do that would improve things for other patients. The learning planner and the learning tracker. The planner is your guide for what you're going to do for the year to help guide your learning. You pick a specific area, and it doesn't mean that that's the only thing that you want to learn this year. It's just the one that you're going to tell us about. And make a plan for how you might approach it. And then in the following year, before you register, you're going to look back at what your learning plan was, what your goals were, what the activities you did were, and how did you achieve those goals, and what did you learn from that, and how it impacts your practice. So those are the steps or the pieces at this point in time in the reflective practice review. Everyone has to complete the essential competency profile at least once. Okay? Usually it's before the first time you renew or the first time you joined the program for those of us that had been practicing for a long time before 2012. It's looking at the essential competency profile that was produced by the Canadian Physiotherapy Association with lots of consultation. You're doing it because our standards of practice state that you are familiar with your competency document and that you're required to meet these competencies throughout your whole career. So it's an exercise to promote awareness of these competencies, similar to what you're doing with the jurisprudence module. Initially, we thought people needed to look at this each year, but we rapidly realized that wasn't necessarily true, so we changed it so that once you've done it once, you are expected to occasionally review and relook at it, especially if you're changing roles or changing jobs. That's a good idea to see where you're lying in your new job, but it's not mandatory every year. However, your learning goal must be mapped or directed at one of these competencies. So it's still important that you understand and reference the competency document. Okay. The patient care reflection tool, Audrey's just going to flip the slide there for me. There we go. Patient care reflection tool, clinicians, full-time, part-time, casual. It doesn't matter if you're working really 5 days a year or every day during the year. If you're treating patients, if you're involved in any part of the patient care process, assessment, treatment, discharge planning, you are expected to complete a patient care reflection tool. You do one each year before renewal, so you need to plan ahead, especially if you're working casually or you're taking some of the summer off, because obviously as it's a patient care reflection, you need access to the chart. So you need to plan and remember that you have to do this before your renewal date. There's a series of questions that try to guide your thinking and your reflection on how you did with the patient. Again, this is a spot where the amount of engagement and thoughtfulness that you put into this will make a huge difference on whether you think this is just a make-work project or whether you find it actually of value and give you some learning. So if you can answer a question, especially if you're working part-time or casually, in some roles you may not do the assessment, the treatment, and the discharge of a patient. You may only have been involved in the treatment area because you were covering someone's vacation or something. You still need to write a note in that box that just explains why you can't actually answer the question. Okay, you didn't set the goals, you didn't discharge the patient, etc. Okay. So every box needs to be filled out, and we're going to go over quickly the audit review in a moment, and what we're looking at as auditors. But just to be aware that we are looking for every box to be filled in and some kind of an explanation if you can't fully answer the question. Okay. The learning planner and tracker, everyone has to do. I can see Audrey's answering some questions. There are a few little different forms, so you'll need to be aware of those. But one form is completed annually and completed prior to renewal. It's an intention statement. It's telling Physiotherapy Alberta what you plan to learn personally or as a project with a group to enhance you or your team's performance, or practice. You need to write a learning goal. Now, a learning goal is no different than writing a patient goal. It's not an activity. It's a goal to, or like if you're doing it with a patient, you would write a functional goal. The patient X wants to walk farther to be able to walk their dog during the day or whatever. It's not the activity. It's an actual goal that your activities are going to help you achieve. Okay. You have to indicate a corresponding competency. So you may be doing something in the expert role. You may be looking at improving some of your practice in the communication area or in any of the 7 competency areas that are in that competency document. Okay. And then we want a rationale for choosing the goal. We want to know why you picked this particular goal to look at specifically this year. Okay? And the more information you put into that rationale, the easier it is for us as auditors to understand what's coming next in the form and what you're thinking about. It also helps you to think about why you want to do it and therefore how you're going to work to achieve that goal and what you're looking at as far as your impact for learning at the end. You need to identify 3 or more learning activities. What are you going to do and where are you going to get your information from? They should be different activities. So a whole list of journal articles, you may list 15 journal articles, is really only one activity. So we're looking at you finding a variety of activities that gather the knowledge, that look at ways to evaluate it or apply it, and so that when you come to looking at your impact of learning in the next year, you have some information to guide you in that impact of learning and figure out, did you actually learn something that was valuable and will make a change to your practice? Okay. Then you come to the tracker, which is the second half of the learning planner. So the learning planner you do in year 1, the tracker you do in year 2, looking back at the activities that you've completed and the amount of achievement of your goal that you have been able to get to. You're going to discuss outcomes in 2 areas. We're looking at personal learning and how it's improved your competence in your practice. On your practice setting, what have you learned that has changed the way you are working with your patients or changed the way that self-service provides care to patients? Okay. Last year the form was changed and we added some guiding questions to help guide your reflection, to give you an idea of more what we're looking for you to come up with. Okay. So the reflective practice cycle is up here. I think Audrey is going to talk to that.
So just as Nancy said, for the cycle, there's some things you have to do before registration renewal. The essential competency self-assessment needs to be completed once and then just reviewed afterwards and revised as needed. It won't be audited. The patient care reflection, if you're a clinician, you complete it, and you complete your learning planner. Then you have the remainder of the year from October 1 to the following time where you renew the following year to complete and implement your learning goal and complete your learning plan. But in preparation for the renewal next year, you would have to also go through the self-assessment process. We are in a transitional year because we have moved to online forms completion, so make sure if you participate in online forms completion that you give yourself time to transfer information from 2015 into the platform, and then time to sit behind a computer and type in and all your responses for your this fall's patient care reflection and also this year's learning planner and tracker. I do want to say anyone who is online who knows that they are going to be audited next year or this fall, we will expect you to enter all of your 2015 information into the platform, so you can start working on it now. And anyone who will be randomly selected for the audit this year, even if you have completed the paper forms or stored them electronically, you will have to enter your information into the online platform. You will also be able to transfer, cut and paste information from your electronic documents into the platform. So this cycle is it's still in place, but as we move to transition to online, there's some additional work involved. So here is the Competence Committee, and my point is I just wanted to say that they're real people, they're your peers. They are responsible for establishing policy and making decisions and recommendations to council about the program, and they also conduct the audit. And this is the group who, after our first audit, said, you know what, we can do a better job, and we spent all of 2015 looking at the audit process and redeveloping the criteria. Nancy, do you want to add anything? Nancy's the chair now. Do you want to add anything?
No, just to let you know that each of these individuals are current practitioners in a variety of different areas, populations, clinical practice areas, and areas of the province. And the goal is to try to assist and guide individuals in our profession to be engaged and be reflective and be more aware of their own competence.
So we have Jennifer Horn, Kelly Stark. Jennifer works in long-term care. Kelly works at Grey Nuns Hospital. She's in management. Shelley Holitsky, who worked in private practice and is in rural Alberta. Rafiq Ansari, who works at the Peter Lougheed Center. And Nuruddin Amusat, who works in neuro and also owns a clinic in Two Hills.
Okay, perfect. So we're going to just quickly go on to looking at what we do when we audit. And the audit criteria, we have two matrices that we use that are very similar to if we're being marked in high school or university, where there's certain numbers or scores given depending on the ability or the amount of information that you've completed in answering the different questions. So if we look at the matrix for the patient care reflection tool, the audit criteria, Audrey's just put it up there for you. You can see that there's four scores. You're scored 1, 2, 3, and 4. 1 being inadequate, 2 being insufficient, 3 is adequate. And we added the 4th category last year, comprehensive, because we really wanted to be able to say to the people who did some amazing jobs that they were above and beyond just satisfactory. So we added the fourth category. Each of several different areas are looked at when we're talking about giving ratings. So the first one is clearly written and easy to understand. That's just, have you completed the entry? Have you, is it professionally done? Is it, look like something that we would expect from a self-directed professional? Sorry, Audrey, go back up to the page ahead. I skipped a little bit. And then, where are we? Sorry, I got lost a little bit here. Audrey, so we're looking at whether things are satisfactorily met, not satisfactorily met, or you have met the requirements and there's no further action. If you are inadequate or insufficient, you will actually be contacted by the program. You will get a result letter with feedback. You will have to resubmit your documents, and they will be re-audited, reviewed by the same auditors to see that you have actually made the changes that we need, that we think would help you in your practice. If you're inadequate and insufficient, you will automatically be asked to be re-audited in the next audit cycle to make sure that the learning that we've directed you to do carries over. If you're inadequate, which means that you really haven't met the program standards in any way, you will be interviewed by the program manager and possibly referred to the registrar or to the Competence Committee to develop a formal plan to remedy the deficiencies and then resubmit the documents. And then, of course, you'll be re-audited in the next year. So if we flip down to the patient care reflection tool, again, we're looking at a variety of different things. Did you complete the entries? Did you, is there evidence that you actually thought through what you were writing, or did you just enter a few different things hoping to get by? Did you benchmark against current external evidence? If you used assessment tools, or if you're using a treatment pathway or guidelines, are you aware of them? If you're treating TMJs or low back pain, there's hundreds of clinical pathways and evidence out there. Are you aware of what's current? And have you demonstrated in your documentation that you are aware and know that there's current external resources? Looking again at current evidence, one of the big things we're looking for is evidence of substantial critical thinking. So that reflection, did you talk about what you did, or did you just report what you did? Did you think about why you did what you did, or did you just say, we provided home exercise programs and as per our normal protocol? Well, what were they? Were they valuable? How did they help that particular patient? This is a reflection on a particular patient's care path, not generally what you would do with all patients who come into your clinic with a total knee replacement. What did you do with this patient? What did you learn? And reflect on the care that you provided to this particular patient as it relates to, and related to, current evidence and current practice. Okay? And then, is it professionally presented? If it's really scribbled and we can hardly read it, and there's all kinds of spelling errors and grammatical errors, that doesn't bode well. It doesn't indicate to us that you are working or taking this process seriously and are actually engaged in providing a quality assessment. Okay? So there are a couple of examples. The first one, I'm not sure, Audrey, can you make it any bigger so it's a little easier to read? There. Okay. So if you look at the first one here, the first question, why did the patient seek treatment with you? She had not received any relief for her TMJ pain. It's lacking in detail. There's not really a clear picture of the patient. And when we go to the next one, so this is a reflection that was found insufficient and has had to be redone. And when we go to the next one, you'll see the difference, okay? We're looking at reflecting on the history, and again, you'll see it's a single statement. It's not really clear. It doesn't really help us address or understand what you saw with this patient. Were the positions and activities described? What information was collected? With the discussion, for example, on the expectations, yes, they were discussed, but what were they? There could be a lot more expansion on that, on those answers. Okay. Skip down to why did you choose the assessment tools? I think that's where, Audrey, where did you go? Okay. A thorough examination of range of motion, but there's no, and it mentions specific measurement tools, but no description of those tools. Are they benchmarked? Are they current? What do you know about them? How and why did you select those specific tools? And as we go further down, you'll see that the answers just are very vague. There's no discussion of the findings to support the diagnosis, no indication of the current literature, why you came up with the decisions you did. Goal setting, the one goal that's talked about to stop putting new pressure on the TMJ. Is that the only goal? And there's no really indication of any reflection on should there be more goals, or are they functional goals, are they relevant goals, SMART goals, that kind of thing. It talks about, it doesn't really even describe the treatment, what treatment was done based on what evidence and resources or guidelines, and really no reflection. So the question wasn't answered. How long did you see this patient? It says normally we would see someone 12 weeks, twice a week. Well, but what did you do with this patient? Okay, and I think the rest of the questions all are kind of the same thing. What would you do with this patient? What did you do? What did you reflect on? And how did things work with this particular patient, as opposed to some very general answers? Okay, if we then flip to the next page, and we're going to have to go through quickly because I see we're running out of time, but you can see in the handouts there are copies of these, and you can see that this individual spent a lot more time thinking about what they did with that patient, what they didn't know, how they found answers to what they didn't know, and what they learned that will improve and enhance the practice for the next patient that comes along with the same kind of scenario. Okay? This is what we're looking for, is evidence that the individual, you were engaged and used this as an opportunity to think about what you know, what you need to know, what you don't know, and what you need to learn, okay, to assist. We then look at the learning planner and tracker. And again, we're looking at the needs to have a learning goal. And a lot of times where people run into problems with their learning goal is it's just way too vague. Or totally not achievable. I want to learn everything there is to know about Parkinson's disease. Okay, well that's pretty big. Or I want to know how to treat geriatric patients or stroke patients. Those are pretty large goals and hard to do in a year. So we're looking at, was it written as a goal that's achievable? Was it just written as an activity? I'm going to attend 10 in-services over the next year. Well, that's an activity. That's not actually a goal that you can comment on. Then looking at your rationale. The rationale is what tells us, if your goal's not totally clear, the rationale gives us a lot more information. Why did you pick this? What are you going to learn from it? How is it relevant to what you're doing and your practice? the learning activities, as I mentioned before, we're really looking for a minimum of 3. One of them needs to have some kind of current external resource, but they also need to be 3 kind of different things, looking at how you're going to find the information, utilize the information, and then potentially evaluate what you've learned and how you've put it into your practice. Okay. The impact of learning, again, we want some evidence in here that you actually have learned something, applied it, and it may be that you've learned that what you're doing is great and is current. It may be that you've learned the goal that you decided to work on really didn't have any relevance that you thought it would, and we need that explained as well. If you didn't achieve the goal or if it didn't achieve the outcome that you wanted, we want to know that as well. Okay? There's a couple of examples of insufficient and a very acceptable one. I'm just going to briefly talk about the insufficient one. Audrey, just make it a little bit bigger. If you can see, the learning goal isn't actually a goal. Further education for staff, self and fellow, physiotherapies is evidenced by at least 1 in-service per quarter taught or attended. Well, that's an activity. For what? What's the goal that this individual wants to achieve? The rationale talks a little bit more. It wants to improve competence and that kind of stuff, but it's still a pretty vague, all-encompassing type of goal. And then when you look at the learning activities, and this is a document that was handed in with the tracker, so all these activities have been completed, we still have no details, no resources. They're really all the same kind of an activity. There's no real evidence of completion. There's a date, but if they were actually completed, then potentially filling in the names or topics of the in-services, where they were taken, did you teach them, did you attend them, that kind of thing. Okay, so very vague. You know that this is not an acceptable plan. And then when you look at their impact on learning, again, very general statements, no real evidence of reflection and clinical reasoning, etc. Okay. I'm going to leave now. You can look at the much more acceptable one that has lots more things in it. The only thing I would add with the learning activities is it would be good to have an activity that actually showed how you were trialing it and or evaluating the new tool. But the impact of learning does describe what this individual felt they found from the program.
Can you hear me?
Yeah, sorry, Audrey.
That's fine. So I just want to point out that this was the resubmission. So the first example you saw was the original submission. They were found to be not satisfactory, and I worked with the member to explain the program in detail, and the second learning planner and tracker is what they submitted. Could we go back to the PowerPoint, because we are running out of time?
I'm sorry.
That's fine. This is important. So I just want to let people know, we wrote about in the July newsletter, we shared the results of the audit of 121 people, and what we found is 90% of people are completing the learning planner and tracker satisfactorily on the first go-round with the Competence Committee, and 98% of people, so only 3 people didn't complete the patient care reflection tool satisfactorily, and most people it's because they are not. We showed you the worst of the patient care reflections. The other 2 people just weren't citing current resources, and that's usually one of the areas that the Competence Committee is looking for. We now have, in terms of selecting people for the audit, we have a bunch of people that are randomly selected, but now based on how we treat things, we give people feedback and an opportunity to resubmit their documents the following year. So we have a directed pool, of which there's a very small number of people. There were 13 people who have been directed because of their audit results. We we have a larger group of people who didn't complete their forms the way we wanted to that are part of this. But in terms of the detailed examination, there were 13 people who the committee wanted more from that are to resubmit their documents next year for review. And then we have a random pool of people who are selected. So overall, people are doing a very good job with completing this program. And on that note, we're not going to talk, you are expected to sign some declarations. The program is going to be evolving. We couldn't come to you before to say what we wanted because 2015 we were developing it. And now after this year's audit, we know what we want. The forms are being revised. The program is going online. The Competence Committee is meeting with council and some thought leaders to conduct a strategic review in September. Several questions are related to the clinical practice. And if you are a clinician and treating patients and charting on patients, you are expected to complete a patient care reflection tool. If you're having problems, I will help you. Just call me or email me. Don't be afraid to ask a question. Okay, in the handout, we have a handout. It says Handout Webinar Reflective Practice Review. That has links to all the articles, and the information is on the website. But call me. Don't try and figure it out yourself. Don't ask a peer. Call directly because each person's situation is different. Even people who are in the first year of the program, what you've been told by us might differ depending on the date you registered for the program. So call so I can look at your information and tell you what we expect.
So there was a question, Audrey, in here earlier about why the need to enter 2 years of information into the platform. Can you explain the new online platform in a little bit more detail in our question time here? I think you caught most of the other questions in the pod.
So in past, the audit criteria and expectations may change based on the platform, the documents that we look at, but we always have asked, well, there's a completion part of the audit, so we would ask for a variety of documents, but only look at 2 in detail, a completed learning planner and a tracker. Because it takes basically 2 years to complete one learning planner and tracker, this year the committee will be looking at your completed learning planner and tracker, which is the one you started last September in 2015 and are finishing up the tracker section, the outcome and impact section. So that 2015 learning planner and tracker will be the focus of the committee's review. So that's why you're asked to enter your information from 2015 and 16. They will also look at a patient care reflection, and it's the most current one, which will be the 2016, 17, 16, this fall's patient care reflection. I hope that answered the question. So the audit looks at some of the documents from different years, and that's why we're asking for that. The self-assessment, when you complete the online platform, when I did the pilot, I put my self-assessment information in 2016, but what happened was it doesn't carry back to the 2015 year. So we're asking that you start on the online platform with 2015, and that self-assessment will carry forward to the 2016 screen, but it doesn't go back. So we're asking that your self-assessment from 2015 be put in, and then you can just update it, review it, whatever you need for 2016.
Okay, and we have a couple of questions about altering information that you're putting online. So Muniswamy asked about editing goals after they're declared online, and VP asked about if you submit online forms this year and are audited, will you have time to review documents before the audit is completed? So can you talk about when access to information happens and how that works when a person is audited versus those that aren't audited but are entering their information in the platform, Audrey?
So in terms of the audit, what will, and I will have to look at this in more detail, but with the paper documents, you receive a notification and you have 30 days to submit. So you have an opportunity to review your information and send it in. Our expectation is when you submit your forms, when you declare at renewal that you've completed it, that they're ready to be submitted. They don't need to be reviewed or revised extensively. You might want to look at them, but our expectation is that they're ready to go. It's done. And in future, with the audit, you will have that opportunity to fill it in. And I don't know the answer of what you are in control once you've completed it. We just have the opportunity to pull it down. So I will have to I will have to communicate about that in more detail in this upcoming newsletter, what it means. But I think this audit platform will change how things are done, how the audit is managed. I haven't answered your question completely because I'm not sure. I'm not sure if we are set up that once you have completed your documents, you no longer have access to them for the purposes of the audit. I can't remember. If we choose to online, so my understanding is, I think if you are submitted for audit, you will have the opportunity to go in and change the information, but I might be wrong. Carla, if we are audited, do they audit only the current year? So I've answered that. We've asked, the rules are structured so that you keep your documents for 5 years, but once we move to the audit on mandatory online forms completion, we are storing your documents and we keep them for 8 years, and then they're destroyed after 8 years. Leanne, are there any other questions? Someone wants to know if they're randomly selected for audit, and there's two groups. There's the random group now, and there's people who have been directed. And the directed people are based on they had been randomly selected last year, and for one reason or another did not meet the program requirements, and so the Competence Committee has directed them.
So if you're not in the random group, you would know that you're being audited. Is that not correct, Audrey? Okay.
Yes. We've sent letters, audit results letters, that have clearly indicated to that member whether they are, whether they're going to be audited this fall.
Okay. And now, how far back do you have to keep your competency forms? How many years worth of these documents do I need to keep?
The rules say 5 years.
Thank you. And I think you've answered the other ones, although Shannon just entered a question, about how to proceed this year. So, Audrey, I'm going to see if I can summarize this, and you can tell me if I go wrong. So when I go to do my online submission of my reflective practice review documents, I'm going to enter my self-assessment. I'm going to do that from 2015, as if I had done it in 2015, so that it would be in the system from then. I'm going to enter my patient care reflection for 2016, and I'm going to enter my learning planner and tracker that I completed already from 2015. Is that right?
So under the 2015 screen, you will enter, so part of it is right. Under the 2015 screen, you'll enter your essential competency self-assessment. I put in my patient care reflection from last year, 2015. I put in my learning planner and tracker, the learning planner portion of 2015. Then I dropped down to the 2016, and it says 2015 implementation and evaluation. So I put in the learning tracker information from 2015. I put in a new patient care reflection. I didn't do anything with my essential competency self-assessment because essentially I reviewed and revised it a little bit. And then I started my 2016 learning goal. So I listed, well, I haven't done it, but I've listed my goal and I've started putting in my activities.
Okay. And Caroline just asked, when will you select those to be audited this year?
I cannot draw the audit sample until November 1. So we know that 30 people, 31, 32 people will be audited. They've been directed, but the random sample cannot be drawn until November 1. So once that random sample is selected, the notices go out about mid-November.
So Audrey, how many people will be randomly selected? Is it 100 or is it 100 total plus those, including those 30 people that are non-randomly selected?
I can't tell you because that's the Competence Committee will make that decision this fall. They will select they make the selection based on a number of factors, their capacity to do the work being one, and then they select from private and public practice, and clinician and non-clinician, and it's a stratified proportional sample, so we look at the proportion of members working in that, in those particular domains, and then we select our sample randomly, the numbers that we select, 9 people from administration, because the number 9 represents the proportion of people.
Audrey, just everybody be aware, it will be probably close to 100 plus the directed ones. The random will run in close to the 100 every year, plus then the directed ones.
Thanks, Nancy. Now, I do note that we have a lot of people still on the line, but we are 10 minutes over time. So at this point, I think that we should probably draw our presentation to a close. Audrey and Nancy have provided their contact information on the screen that you can see in front of you. I know that many people have questions about the Continuing Competence Program, and you're strongly encouraged to contact Audrey or Nancy directly, and Nancy has also placed her phone number in the question and discussion pod. So if you prefer to call Nancy rather than emailing her, you certainly can do that as well. I believe we've covered the questions that are in the chat pod, but if I've missed one, I apologize. But as I say, I believe we do need to draw our meeting to a close. Thank you very much for your attendance this morning, and thank you very much, Audrey and Nancy, for your presentation. It was very well attended. I think that speaks to the interest that physiotherapists have in meeting the expectations and requirements of the program. And so with that note, I'm just going to put our fluid survey of this presentation back into the discussion pod so that people have the ability to answer some questions about today's presentation and about the program. And again, I'm going to encourage you to contact Audrey and Nancy directly if you have further questions. So thank you very much, Audrey and Nancy.